Welcome to Board Pearls. This is episode 3 of the Autoimmune and Cholestatic Liver Diseases chapter in the Liver Disease module. This episode is primary sclerosing cholangitis and its steroid-responsive mimic, the multifocal stricturing disease of the man with inflammatory bowel disease with no proven medical therapy and surveillance for 3 cancers, and IgG4-related sclerosing cholangitis that looks like both sclerosing cholangitis and cholangiocarcinoma but responds to corticosteroids. The patient is a man in his late 30s or 40s with ulcerative colitis whose alkaline phosphatase has crept up on a routine panel. He feels fine. The transaminases are mildly elevated, and the bilirubin is normal. That setup is primary sclerosing cholangitis until imaging proves otherwise, and the favored stem is built around the male ulcerative colitis patient with cholestatic labs because that's where the diagnosis lands most of the time. The disease is chronic immune-mediated inflammation and fibrotic stricturing of the intra- and extrahepatic bile ducts, probably running through the gut-liver connection where aberrant gut-derived T cells home to the biliary tree in a primed host. And the central epidemiologic fact is the association with inflammatory bowel disease, since most sclerosing cholangitis patients, roughly 3/4, have concurrent IBD, almost always ulcerative colitis, though the reverse rate is much lower, only a small percentage of IBD patients developing it. The biochemistry is cholestatic. The alkaline phosphatase typically a couple of times normal, and the transaminases under 5 times normal, unless there's overlap or acute obstruction, with one trap the boards exploit. The alkaline phosphatase fluctuates and is often normal, nearly half the time, so a normal value doesn't exclude the diagnosis, and if the demographic and IBD context fit, the next move is imaging, not reassurance. The imaging answer is MRCP, the test of choice because it performs comparably to ERCP while being non-invasive and avoiding the cholangitis risk of instrumenting a strictured, colonized duct. And the pathognomonic finding is multifocal short-segment strictures with intervening normal or dilated segments producing the beaded appearance, which can be intrahepatic, extrahepatic, or both. ERCP is reserved for therapy, not diagnosis, indicated for a dominant stricture, ascending cholangitis, or suspected cancer, and ultrasound is neither sensitive nor specific. Biopsy is unnecessary when the cholangiogram is diagnostic and is required in 2 scenarios: small-duct disease, where the cholangiogram is normal and the diagnosis still has to be made, and suspected overlap with autoimmune hepatitis, where the histology answers whether there's an interface hepatitis component needing immunosuppression, and when a biopsy is done, the classical lesion is concentric periductal onion skin fibrosis, highly specific but uncommon on any single biopsy because the disease is patchy, so most biopsies show nonspecific portal. One rule the boards reward is to add an IgG4 stain to every biopsy, because IgG4-related sclerosing cholangitis hides inside the phenotype and its treatment is completely different. Small duct disease, where only the small intralobular ducts are involved and the MRCP is normal, is a small fraction of cases, has a better prognosis with lower rates of cancer and transplant, and a minority progress to large duct disease, so it's a distinct lower-risk phenotype, not a benign finding. And the antibody profile reinforces one point that trips candidates. There's no diagnostic antibody, the atypical p-ANCA positive in most patients, but also across many autoimmune diseases, so it's non-diagnostic, the mitochondrial antibody essentially always negative, and an elevated IgG4 moving the diagnosis elsewhere, so this is an imaging diagnosis closed by the cholangiogram, not the serology. The natural history was clarified by a large cohort showing transplant-free survival around 2 decades from diagnosis, considerably better than older referral estimates, with mortality dominated by cholangiocarcinoma and end-stage liver disease. It's a premalignant condition which drives almost everything in management because there's no proven medical therapy that changes the trajectory, so the work of management is surveillance for 3 cancers plus a smaller 4th. Cholangiocarcinoma is the dominant one, with a lifetime risk of roughly 1 in 10 to 15, an annual incidence of about 1%, and the risk highest in the first year or 2 after diagnosis, which matters because patients are sometimes diagnosed with the cancer and the sclerosing cholangitis simultaneously on the same cholangiogram, with the premalignant lesion being biliary dysplasia and the risk enriched in older patients, men, long-standing colitis, and dominant strictures. Surveillance is annual MRCP plus a serum CA 19-9 in adults with large duct disease, starting at diagnosis, and the CA 19-9 is imperfect, rising with cholangitis and in many cholestatic states, and uninformative in Lewis-negative patients who can't make the antigen at all. so a markedly elevated value raises suspicion but doesn't establish the diagnosis, and the interpretation that matters most is the trajectory rather than the absolute number, since a value that has departed from the patient's own baseline is the signal that drives further work. The dominant stricture is the named entity anchoring much of the content, a single stenosis disproportionate to the overall pattern. And while there are numeric definitions, the operational one is the stricture that stands out. Dominant strictures develop in a substantial fraction of patients, presenting with new jaundice, pruritus, weight loss, or recurrent cholangitis. And the reasoning that matters is that every dominant stricture must be assumed to harbor cancer until proven otherwise, especially with weight loss or a rapid biochemical change. So the workup is ERCP with brushings, molecular testing for chromosomal polysomy, and often cholangioscopy with directed biopsy, with treatment being endoscopic dilation with or without short-term stenting after malignancy is. The teaching point the boards exploit is the diagnostic ceiling of brush cytology, with a false negative rate over half for cancer in this disease, because the tumors are scant in cellularity, grow longitudinally beneath the epithelium, and look cholangiographically like the rest of the disease, which is why the workup layers the molecular test on top of cytology and reaches for cholangioscopy-directed biopsy when both are negative but suspicion persists. So a negative brush is not a clean bill of health when the picture is rapid jaundice, weight loss, and a new dominant. A patient with a Cholangiocarcinoma may then be a candidate for the neoadjuvant chemoradiation and transplant protocol, with the selection criteria being a mass under 3 centimeters, no extrahepatic spread, and no transperitoneal biopsy of the primary tumor, with good survival in selected protocol patients. Gallbladder cancer is uncommon in absolute terms, but the risk per polyp is dramatically higher than in the general population, which changes the surveillance answer. The cholecystectomy threshold is set at polyps greater than 8 millimeters, a lower threshold than the 10 millimeter cutoff used in the general population, precisely because the malignancy rate per polyp is much higher, with polyps 8 millimeters or smaller followed by ultrasound every 6 months, often paired with the surveillance MRCP, so the candidate who applies the general population 10 millimeter rule to this patient has used the wrong denominator. Colorectal cancer surveillance is the third domain and the strongest argument for rigorous colonoscopy, because the combination of sclerosing cholangitis and IBD enriches the risk several-fold over IBD alone even when the IBD is mild or in remission, with the phenotype being pancholytic with right-sided predominance and the cancer often arising in flat dysplasia. So colonoscopy with random and targeted biopsies is done at the time of sclerosing cholangitis diagnosis, regardless of how long the IBD has been present, then every 1 to 2 years, and a fraction of patients have subclinical IBD discovered on that first colonoscopy, so the teaching is that the diagnosis resets the IBD surveillance clock to start now and tightens the interval to every 1 to 2 years. Hepatocellular carcinoma is the smaller fourth domain, uncommon here compared with viral or metabolic cirrhosis, so surveillance with ultrasound and alpha-fetoprotein every 6 months applies only once cirrhosis develops. The mental map reads cholangiocarcinoma, gallbladder, and colorectal as the dominant 3, with liver cancer a quieter add-on. The non-malignant complications rounded out: recurrent bacterial cholangitis treated with antibiotics and short-course stenting, portal hypertension appearing even before frank cirrhosis, pruritus running the same mechanism-targeted sequence used in primary biliary cholangitis, and fat-soluble vitamin deficiencies as cholestasis advances. There is no proven medical therapy, which is the single most important negative fact, and high-dose R-sodioxycholic acid, above 28 milligrams per kilogram per day, was tested in a large trial and the result was worse, not better, with increased mortality, transplant, and colorectal neoplasia, so high-dose R-sodioxycholic acid is contraindicated. Standard dose hasn't improved outcomes and isn't formally recommended. And vancomycin lowers the alkaline phosphatase in small studies, but lacks survival data and isn't the standard answer. Liver transplantation is the definitive therapy for end-stage disease, indicated for decompensated cirrhosis, refractory pruritus, recurrent bacterial cholangitis affecting quality of life, and hilar cancer within the transplant protocol, with mild exception points available for recurrent cholangitis because the score underestimates its morbidity and the disease recurs in the allograft in a fifth to a quarter of recipients. The disease that mimics this entire picture deserves the second half, because misdiagnosis costs the patient an effective therapy. IgG4-related sclerosing cholangitis is the hepatobiliary manifestation of IgG4-related disease, a systemic fibroinflammatory disorder, with its own histology, its own imaging signature, and a remarkable response to corticosteroids, and it's the most common extrapancreatic manifestation of the disease, with about 7% of patients whose cholangiogram looks like sclerosing cholangitis actually having this instead, which is why serum IgG4 is checked at every new diagnosis and the biopsy stain belongs in the routine workup. The demographic and presentation differ in ways the boards exploit. The typical patient is a man over 60 rather than over 40, presenting with painless obstructive jaundice and often weight loss in a pattern that mimics pancreatic or biliary malignancy more than it mimics sclerosing cholangitis, with the pancreas involved in most cases as autoimmune pancreatitis, the sausage-shaped gland with a capsule-like rim on imaging, and other organs sometimes involved, and importantly no association with inflammatory bowel disease, so that absence is itself a clue when a patient who looks like. The cholangiographic pattern differs too. The strictures are tight and segmental from inflammatory masses in the duct wall, with long sausage-like dilations between them rather than the discrete short-segment beating, dominated by distal common bile duct strictures, often with pruning of the peripheral ducts, so that pruning plus sausage cholangiogram in an older man with painless jaundice and a sausage-shaped pancreas is not sclerosing cholangitis. It's this disease, and the patient should not go to a Whipple. The diagnosis is framed by the HISORt criteria for histology, imaging, serology, other organ involvement, and response to therapy. The histologic triad is a dense lymphoplasmacytic infiltrate, storiform swirling fibrosis, and obliterative phlebitis, with the biopsy showing many IgG4 positive plasma cells and an IgG4 to IgG ratio above 40%, and the serum IgG4 elevated in most cases but neither perfectly sensitive nor specific, because modest elevations occur in sclerosing cholangitis, in cholangiocarcinoma, and in other inflammatory states, which is why histology and imaging and other organ involvement all carry weight along. The treatment is corticosteroids, and the response is dramatic, with prednisone at 40 mg daily for 4 weeks, then a taper-producing resolution of strictures, normalization of the alkaline phosphatase, and shrinkage of the pancreatic involvement within weeks, and that response is itself part of the diagnostic framework, which is why the response to therapy earns its place. Relapse is common, up to half, so azathioprine, mycophenolate, or rituximab are added for steroid-sparing maintenance or refractory disease. So the favored vignette is the older man with painless jaundice, a distal common bile duct stricture, pancreatic enlargement, and an elevated IgG4, where the answer is to check IgG4, biopsy with the stain, and trial steroids, not to default to presumptive sclerosing cholangitis management, and not to schedule a Whipple. The two overlap syndromes belong here because they sit at the edge of the three disease sort. The overlap of autoimmune hepatitis and primary biliary cholangitis is the most common, where a small fraction of primary biliary cholangitis patients develop a hepatocellular component, and the diagnostic shorthand requires satisfying at least 2 of 3 features for each disease. For the hepatitis, a transaminase at least 5 times normal, an elevated IgG or a positive smooth muscle antibody, an interface hepatitis on biopsy, and for the biliary disease, an alkaline phosphatase at least twice normal, a positive mitochondrial, with treatment being combination, ursodeoxycholic acid for the cholestatic component and prednisone, with or without azathioprine for the hepatocellular component, because single-agent therapy underserves these patients as either component progresses if untreated. The overlap of autoimmune hepatitis and sclerosing cholangitis is rare in adults and more common in children, requiring hepatitis features in a patient with the cholangiographic findings, treated with ursodeoxycholic acid, plus immunosuppression, with the hepatitis side often responding clearly and the biliary side stable or slowly progressive because there's no proven therapy for it. So the way of thinking is recognition-driven. Sclerosing cholangitis is the cholestatic disease of the man with ulcerative colitis, diagnosed on MRCP rather than serology, with the alkaline phosphatase normal in nearly half of patients at any moment and the cholangiogram closing it when the demographic and IBD fit. It has no proven medical therapy, and high-dose ursodeoxycholic acid actively worsens outcomes, so the work is surveillance for 3 cancers, annual MRCP plus CA 19-9 for cholangiocarcinoma, annual ultrasound for gallbladder polyps with cholecystectomy at greater than 8 millimeters, and colonoscopy from the time of diagnosis every 1 to 2 years for the flat dysplasia right-sided cancer, with transplant the definitive therapy and MELD exceptions available. And IgG4-related sclerosing cholangitis is the steroid-responsive mimic living inside the phenotype, the older man with painless jaundice and a sausage-shaped pancreas, where the answer is IgG4 testing, biopsy with the stain, and a steroid trial. The next chapter turns to steatotic and alcohol-associated liver disease, the fatty liver nomenclature and cardiometabolic criteria, non-invasive fibrosis assessment, lifestyle and bariatric surgery, and the new pharmacotherapy, along with alcohol-associated liver disease, with steroid therapy for severe alcoholic hepatitis and early transplant for selected patients. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of Chapter 20, and I'll see you in the next one.